Greetings and welcome to Lobes and Robes, How Neuroscience Can Change the World. This podcast is sponsored by the American University Center for Neuroscience and Behavior and explores the links between neuroscience and key policy questions today. I'm Susan Carl, a professor of law at American University Washington College of Law, and I will help lead discussions throughout our series along with Dr. Terry Davidson, Director of the Center for Neuroscience and Behavior at American University and a distinguished professor of neuroscience here. This podcast is for anyone interested in how scientific discovery can make the world a better place. Thanks for listening.
The United States is on the cusp of a psychedelic renaissance. Across the country and many parts of the world, interest in the use of psychedelic drugs to treat depression, anxiety, PTSD, substance abuse, and other disorders has grown dramatically. However, this increased interest is also generating many questions about the safety and therapeutic effectiveness of these drugs and about the methods used to study them. Our guest on this episode of Lobes and Robes is Dr. Matthew Johson, senior researcher at Sheppard Pratt Institute for Advanced Diagnostics and Therapeutics. Over the past 20 years, beginning while he was a member of the faculty at Johns Hopkins University, Dr. Johson published dozens of papers in prominent scientific journals that investigated the potential of psychedelic drugs as therapeutic tools. He is also an expert on the risks associated with the study and use of psychedelics and on the safety practices that can mitigate these risks. Dr. Johson has shared his expertise with Anderson Cooper on 60 Minutes, and he has been interviewed by New York Times, the Washington Post, the Wall Street Journal, CNN, NPR, Fox News, the BBC, among other outlets. We are delighted and honored that he is joining us on this episode of our podcast. Dr. Johson, welcome to Lobes and Robes.
Welcome.
Oh, my pleasure to be here.
So there's lots of research showing that conditions such as depression, mild cognitive impairment, post-traumatic stress disorder, addiction, and the psychological effects of cancer and other serious illnesses may respond favorably to treatment with psychedelics. Could you summarize for our listeners what the current scientific research shows about the positive potential of psychedelic drugs for therapeutic uses for these conditions?
Sure. It's important to make clear that a lot of things are being studied. Only a subset of those have actually been investigated in clinical trials. So, for example, mild cognitive impairment, there's some rationale for it. There's some anecdotes, but there's no evidence from any human research, any clinical trials. But yeah, where we're at is the first clinical indication in the modern era that was investigated therapeutically was the work looking at cancer distress. So these are depression and anxiety symptoms within cancer patients, essentially people that have what you could call existential anxiety due to potential death. So it has to be a life-threatening illness. And colleagues and myself published the first research on that in 2016. And this was years, a decade after kind of more preliminary work with so-called healthy normals, so non-therapeutic studies where we're just trying to understand the effects, but not necessarily treat a disorder. But now several groups have published in cancer-related distress, and all coming to the same general conclusion, the controlled trials finding pretty large and statistically significant reductions in depression and anxiety that aren't seen in the various control conditions. That led to work in major depressive disorders. So this is outside of cancer, people with what most of us would just call depression, where psilocybin, and I should say the majority of the work with psychedelics has been in the modern era, has been with psilocybin. There's also some work with MDMA, which I'll get to, but it's with psilocybin, which is the compound in mushrooms, so-called magic mushrooms. And so several studies have found, including clinical trials, positive effects in reducing depressive symptoms. There's also the work on addiction. The two primary things that have been looked at in clinical trials is the line of research that I have initiated and conducted using psilocybin to treat tobacco addiction. And there's also the work spearheaded by Michael Bogenschutz, which has looked at alcohol use disorder, what was called alcoholism in the older days. And that was picking up on threads of LSD research in the 60s on alcoholism. And there's other things under investigation. Our colleague Peter Hendricks in Alabama is nearing the completion of a trial of psilocybin for cocaine addiction, so we're anxiously awaiting those results. And there's some other disorders that have been looked at, including distress amongst long-term AIDS survivors, which is an interesting indication, like the cancer-related diagnosis, which isn't nominally in the DSM, the psychiatric Bible, but it seems clear it's a real and distinct phenomenon. This AIDS survivor syndrome, it's been called, and there was some pilot work in that which looked promising. And moving outside of psilocybin, the major work, in fact, the most clinically advanced work has been with MDMA. MDMA, people know it as Molly or ecstasy in terms of recreational use, but it's not a so-called classic psychedelic. It works in a different way in the brain than the classic psychedelics, psilocybin, LSD, DMT, mescaline. But it's shown some pretty promising findings in the treatment of PTSD. And I say it's the most advanced because 2 phase 3 trials have been completed, and it's currently under evaluation by the FDA, which could potentially approve it for treatment in August, although that's a little iffy because there was a pretty rough advisory panel meeting within the last several weeks where the advisory panel actually voted. This is a non-binding vote, but their recommendation was not to approve it at this time. The other work with psilocybin is all earlier phase, at most phase 2 work. Some entities are working on phase 3 work as we speak of psilocybin for depression treatment. And phase 3, for the listeners, phase 3 is that final phase where the FDA will take those phase 3 results and decide yay or nay, should this be approved for treatment or not. So it's at various stages of research, and this is all indication specific. So, it's not just that, like, if psilocybin is approved for depression, it would be for depression. Those other lines of research, psilocybin for various forms of addiction, would still need to be continued.
What we see often in the popular press media is, and has been for a long time, it used to be stories about bad trips and so on with psychedelics. And more recently, what we've been seeing is an increase in the kinds of stories where there's been miraculous kind of recoveries and responses to folks who have been alcoholic for many years, or folks who've had PTSD, who've had dramatic improvement in their conditions. Where's the research really stand on those with respect to those kinds of anecdotal reports? Do they seem to favor one view or the other, or something totally different?
I've done research on the good, the bad, and the ugly. I've really made it a focus of my career from the beginning to understand the risks and to highlight them in some key publications, and to conduct novel research on risks and develop scales for risks. And so the answer is both are true.
I see.
It's a large landscape. The bad trip is an absolutely real phenomenon. One should never underestimate how psychologically intense these experiences can be. And in an unsafe setting, it can result in harm, dangerous behavior, sometimes death. It's important to highlight it's pretty atypical for major harm to unfold. Usually a bad trip resolves itself and person doesn't do anything dangerous during that time. But it's a big world, and the risks here are lower than the typical harms associated with other major recreational drugs, be they legal or illegal. But nonetheless, there is a reality there of people panicking and running into traffic or falling from heights, or some of these things that were overplayed in the propaganda in the late 60s, but there is a real kernel of truth there. And it's also just a really frightening experience some people may not want to have. The other major category of acute harm is just destabilization of people with severe psychiatric illness. And so we have a lot more to learn about that, but the best evidence observationally would suggest that people with some of the psychotic disorders, for example, schizophrenia, or an identifiable predisposition for developing those disorders. And this is the type of thing you can assess with psychiatric interviews and a screening and through a psychiatric history, that those people can become destabilized. So we've never seen a convincing case where someone who's psychologically healthy can have a psychedelic experience and it makes them go mad. They go on a trip and they never come back. However, there are examples of people who appeared to have some premorbid or, active psychotic disease. And it seems pretty convincing that it worsened their symptoms. And I would say that's probably in the category of major destabilizing life events are known to, worsen disease for those individuals. So there's a reality on both the good and the bad. And I do want to remind people that, despite some of the really positive life transforming experiences that you get in therapeutics, and sometimes, and I've done research on this through surveys of sometimes people get it out of the blue, even when they are taking it, just for fun. In addition to that, as well as the horrific bad trips, the most typical psychedelic experience are neither one of those. It's someone who's taken it and when they were young in college, for example, or high school, and they had a good time. Maybe it got a little scary, but it wasn't. No one was harmed, and it's an interesting memory. So that's I always want to remind people that's the more typical psychedelic experience for most folks.
So, Matt, let me follow up. I know that you've done a lot of research on tobacco addiction. And so does it work? Do psychedelic and psilocybin, I think, is where your focus has been. Is it effective treatment?
It appears to be. It hasn't met that phase 3 standard yet that I described earlier. But I recently wrapped up a trial randomizing people to either a single psilocybin session or a standardized course of nicotine patch treatment, both with the same cognitive behavioral therapy, talk therapy, which is sort of the standard talk therapy used to help people looking to quit smoking. And we're roughly doubling the success rates.
That's great.
6 months and a year out. So that's looking very promising. And these are relatively high success rates. I mean, even the successful treatments we have, the medications, even for those, even though they outperform placebo and other conditions and control conditions, nonetheless, it's 6 months, a year out. It's a minority of people. A typical result, maybe 25% of the people in the experimental condition are still smoke free. And that might be compared to 15 or 10% in the control group. So you'd rather have a 25%,
sure,
rather than 10%. So all of these things work. The medications that are approved work in that sense. But the bigger story for me is there's so much room for improvement. Most people are still smoking at these long-term follow-ups. So we're seeing so far the majority of people at those long-term follow-ups, still smoke-free. So across both the initial pilot study and a recent randomized trial, and we're now conducting a double-blind multi-site trial that's funded by the NIH that'll provide an additional lens. So we'll have to stay tuned for those results.
That sounds really important finding. I'm wondering, what is your theory about why taking psilocybin works this way? What's going on in the brain that causes these results? As far as I realize, nobody really understands completely, but what is your understanding at this point about what's happening?
It's probably important to define the treatment model and let folks know that really all of this psychedelic work that we've been talking about has unfolded in conditions under which the psychedelic is only administered 1, 2, or 3 times across these various trials. So it's a very different paradigm than administering a pill once a day. So this isn't, sometimes people that don't understand it will say, of course, it's easy not to smoke if you're, tripping your head off all day. That's not the model. It's not a so-called agonist or substitution treatment like methadone for heroin addiction or, nicotine gum for smoking tobacco addiction. So that really kind of highlights the importance of the question that you posed, Susan, like how in the world could something have this change in the brain acutely, in other words, when the drug is active during those 6 hours, that is making people less likely to smoke or be less depressed, et cetera, months later. I mean, that's a really challenging pattern to explain. And I think most broadly, the explanation is that this is more like psychotherapy. People learn from these experiences. So what we do know is acutely a whole lot is happening when the drug is in your system. The brain, probably the most important thing is that brain communication patterns at a molar level. So when you do things like resting state imaging and looking at the pattern of communication across the synchronization of activity across different areas, you see dramatic changes in that network activity. And that's probably consistent with the extremely altered and intense subjective effects, where you have any number of things, novel perspective taking. You have oftentimes a dissolution of the subjective subject-object distinction. And gets kind of deep, but it's a transcendental type of effect that's sometimes referred to as a mystical experience. People can have an experience of oneness where they don't feel like there's a differentiation between themselves and everything else. So you can have these strong alterations in subjective experience that can have a lasting psychological impact on people. And I have seen evidence in studies where, for example, the greater mystical experience, a core component of that is this sense of oneness, shows some relationship to long-term therapeutic effects, even when you statistically control for how strong they rated the drug effect to be, how intense. So it's not just like getting hit over the sledgehammer with the drug effect, but it's the psychological nature of what they experience during that drug effect that seems to have some impact, which goes back to the point that it seems more like psychotherapy. When you talk to someone long-term about how they think it helped them, they'll talk about, well, here's how I viewed myself before. This is how I viewed myself now. This is what I experienced during the session, and it taught me this. Or it's like when you ask someone how, a life experience or how some shift in life, like marriage or being a parent or visiting another culture, or, getting older, changed them. Or a successful course of psychotherapy. It's like, oh, this is what I learned. This is how my patterns were before, and now here's how my habits have been changed on a daily basis. And they have a narrative about how they changed. And so it's more like that than typical psychiatric medication, where it's really the treatment of the surface level, the symptoms, which, I'm a fan of all of this. There's nothing wrong with treating symptoms. We need more tools in the toolbox rather than fewer. But I do think there is a difference, and there's a reason why the psychedelics are tending to show such large effects, is because they really can get to the psychological roots of some of these psychiatric disorders rather than just treating, the surface level. Like you can tweak serotonin receptors, by augmenting extracellular serotonin. For a certain number of people, it's going to take the edge off of some of the depressive symptoms. Someone who's trying to quit smoking, you could replace that with a safer form of nicotine in their system that kind of quells the receptors that mediates that drug craving. And this is all sort of like treating the symptoms. Or you could provide a GABAergic drug like the benzodiazepines to treat anxiety, but again, symptom relief. So it really does seem that we have a lot to learn about, and we could talk more about the biology. We know what receptors are hit. We know something about how that leads to these long-term, this more molar change in brain network activity. But I think ultimately the key is that those biological changes, which are only in place temporarily, do lead to an experience that is psychotherapeutic in nature, particularly when you optimize the intention and the setting.
That is so fascinating. So it's the fact of hallucination is part of what makes, so you couldn't experience the beneficial effects if you didn't hallucinate. Is that sort of what you're saying? Or
well, it's an empirical question. And in fact, there's some really fascinating investigation. It's way earlier stage of so-called non-psychedelic analogs, non-psychoactive analogs of these psychedelics. So a component that I haven't mentioned part of this complex picture is that we do have evidence in rodents that there are multiple forms of neuroplasticity. So ways in which brain cells can change either through creating new branches, creating new connections among neurons, or even some evidence for the growth of new neurons. Although we have a lot to learn. Something I like to remind folks is that a lot of drugs of abuse, such as cocaine, are also can increase neuroplasticity. So we have a lot more to learn about whether there's something unique about these forms of neuroplasticity with psychedelics. But my best guess is that part of that neuroplasticity is part of this complex causal mechanism, and maybe a double, triple, quadruple whammy, to use a very specific scientific term. There may be multiple mechanisms that kind of create a perfect storm for a therapeutic effect. And it may be that neuroplasticity is part of it, sets the stage for what we psychologically call increased mental flexibility, an increase in personality openness. All of this has been demonstrated in the days following the psychedelic experience. Now, I bring that up because some, particularly companies that are developing some of these novel analogs, that they've figured out ways where you can have similar neuroplasticity without having an overt psychoactive effect. And it may, in fact, as some of this is in animal work, when it gets to the human level, we may find out that there's a minimal psychoactive effects to some of it. But the hope is to have no or minimal psychoactive effect. And I think that's worthy of pursuing. I do think if that works, it would be a different treatment model. I think it's extremely unlikely you're going to have 1, 2, or 3 sessions with the compound and you're going to see, benefit months later. I think if there's something to this acute neuroplastic effect by itself, that would need to be administered on a more chronic basis or in some very specific way with a standardized course of psychotherapy, maybe increasing the propensity for learning in those therapy, in the same way that scientifically there's some work around D-cycloserine and similar compounds have been shown to enhance extinction-based exposure therapies for anxiety disorders. So for the models that we're dealing with now, where you have what's called a heroic dose, 1, 2, or 3 doses where there's this strong, psychedelic experience and you see benefit months later. For that, I think the evidence suggests the subjective effects are necessary, but I don't want to preclude the possibility that other treatment models, probably with more chronic administration, where you could get something where you've taken out that subjective experience.
So with respect, comparing a heroic dose to practice, it's called microdosing psychedelics. And apparently that's become popular in certain segments of our society. Do you think microdosing is effective in any way with respect to its therapeutic use?
It might be, but we know far less about it. So this is largely anecdote. The few studies that have been credible to really hone in and test microdosing under a double-blind condition, which I would argue is especially necessary for the more subtle claims that are talked about in microdosing, that, you felt just a little more creative, or you had more attention, like an ADHD medication, or you just kind of were a little bit more of a flow state. And to be clear, with microdosing, people talking about they're taking it a few times a week or a couple times a week, not every day, but more in a chronic fashion. And you take it and you go to work. You take it and you engage in life. It's not like the psychedelic model, the heroic dose model, where, I don't know if I said this before, but another part is that, you're not walking around doing things. You're laying on a couch or on a bed for those 6 hours. You're being watched over by professionals. And so this is a very different model with microdosing, where you take the idea is a tiny bit of the substance, where the effect is either indiscernible or barely, more at the level of a cup of coffee. You could maybe feel it, but it's certainly not an overt psychedelic effect. And the idea is that you get some of these improvements I described. The credible research that's been double-blind has failed to show any benefit. But there's only been a few of those studies, and so it may be, as a field, we haven't looked at it through the right lens. So I don't want to preclude. And I am open particularly to the idea that there could be some antidepressant effects Because when you think about it, going back 70, 80 years, even with the oldest generation antidepressants, the mechanism has always been for traditional antidepressant effects has always been augmenting extracellular monoamine availability. As we found out over time, and the drugs have gotten more specific, it's really the serotonin that seems to be one of the keys to that. So this would be another way of chronically augmenting the serotonin systems. It wouldn't be surprising if that had some effects on depression, perhaps at the expense of a slight increase in anxiety, because we certainly know that higher doses of psychedelic compounds increase anxiety. And so far, the double-blind microdosing studies have suggested a slight increase in anxiety for people. But we need more research. And I would say, finally, if there was efficacy there, which I'm open to, it would probably be, the argument would be similar to that for the non-psychedelic analogs that I described earlier, that if microdoses are working, it may be because of an effect on neuroplasticity. And therefore, like I said earlier about the non-psychedelic analogs, that would be consistent with the fact that people are taking microdoses more chronically. One final thing I'll say is that people, this is definitely the unknown, and there is some concern about most of these psychedelics have an effect on what's called serotonin 2B, which is a mechanism that is not necessary for the psychedelic effect, but it can lead to, we know this very well mechanistically, hardening of heart tissue. And this, for example, is why fen-phen weight loss drug was pulled from the market, 25 years ago or so, that there can be this heart valvulopathy, it's called. And so we don't know that that's happening with psychedelics when you take them on a chronic basis, but it's certainly theoretically possible. Sure. And so I do think people should be aware of that risk if they're taking these things for months and months and months and years.
Yeah, and probably saw this of all the places in the Wall Street Journal, an article about how these professional upper middle class women were microdosing. Instead of having their normal 2 glasses of wine after work, they pop a few mushrooms. And I wonder what you think about sort of the effects of that kind of media attention. I would encourage people to go ahead and give it a try. Do you see public health dangers from the sort of unregulated use of these drugs?
Yeah, and to be clear, there's a lot of nuance to this conversation. I personally think the data and just human rights, suggest like we should not be using criminal penalties as a way to minimize the harms of drug use. However, there's a lot of, you name the substance, there's even for caffeine, there are harms out there. And so it's a question of what are those harms? What do we know about it? What can be done to minimize those harms? And so, on the ground, one of the concerns, I already mentioned the theoretical risk to heart disease of chronic microdosing. But another concern, I've heard from people about this, they intend to microdose, but then they're at work or they're watching their kid and they, the walls start getting wavy, they start tripping and, people are, yes, there are ways to, be more rigorous and, make sure you're taking a smaller amount, but people are people. And even if they know about those methods, they just say, they take the little, they kind of cut up the mushroom in multiple ways, or they take the blotter paper of LSD and they cut it up with a little pair of scissors and you might have most of the drug on one little corner and you don't realize it. And so, so those risks as well. And so we just don't know. And it is, I'm personally less interested in the microdosing phenomenon. I mean, I'm interested, but if there's efficacy there, it's kind of more, it's not the paradigm shifting effect. It's going to be more like traditional, mental health treatments, like, Adderall, or, the amphetamine type stimulants, especially if someone doesn't have a tolerance, they're going to feel in the flow. They're going to feel sometimes more creative. They're going to have more energy. They're going to be in a better positive mood. Sounds a lot like, and even, especially again, if you don't have tolerance, like if you're not a caffeine user, just 100, 200 milligrams of caffeine will cause those things and put a little more pep in your step. And so, I'm not convinced about how special microdosing is. And it's again, not that, I'm not sure if it's a unique effect. And, and if it's something that someone is in some sense dependent on, in other words, to maintain the benefits that they have to keep using it, it's always going to be a risk benefit ratio. There could be some medical risk to chronically using. There could be some impairment. We also know from that microdosing research that one's ability to judge time is slightly impaired. Not surprising at all. This is not a problem when you're on a big dose, laying on a couch for 6 hours, watched by professionals. You can welcome the time distortion, but you don't want that when you're driving your kids to daycare, and you want to be accurate in your timing and going about your everyday life. So, I am concerned about, while not being a puritanical, shame on people for taking substances, I do want people to be well informed and know that there certainly are risks to any substance you're taking. And you should know that, whether it's alcohol or caffeine or, psychedelics.
Absolutely.
Well, so I have a question, and that has to do with, you mentioned the ratio of risk to benefits. And I know your work and a lot of the research that's on psychedelics uses the heroic doses. And you talked earlier on about how large doses can have negative effects as well as potentially positive ones. Yet I also know that you've been very concerned about reducing those risks. And I'm wondering if you could tell us a little bit about what are the best practices with respect to reducing risks, keeping people safe, both in an experimental setting, as you often work, and also as how these drugs might be applied as therapeutic interventions.
And I want to throw in a related question here too, which is both in reducing risk. And I also know you are one of the most respected researchers on the ethics of using psychedelics for both research and treatment. So maybe you could lay out your work that sort of combines risk, safety, and ethics, and discussing your thoughts about best practices to address that set of issues.
Great. There's a lot. I'll go through it pretty quickly. So, in research or in treatment, I think there needs to be screening. And even in terms of harm reduction, and to be clear, I don't encourage anyone to use any substance, legal or illegal, but I do feel okay saying, hey, I'd want people to know what differentiates riskier use from less risky use. And if someone's going to use, better to know what constitutes less risky use than more risky use. So, what we do in these studies and what I would expect for treatment, and, the conditions under which you're going to see the less risky use, even when people are using on their own, are the conditions under which you have some confidence that the person doesn't suffer from a psychotic disorder, or there's no kind of early signs that they might suffer from one of those disorders like schizophrenia, where they don't have a more severe level of heart disease, because the response is pretty modest, but these drugs can typically have a very real effect in increasing pulse and blood pressure. Not a problem for the large majority of people, but it can be a problem for those people. If your doctor says, don't take the stairs at work, don't shovel snow, you're probably in the category where there is some risk of taking any substance that increases your blood pressure, like psilocybin or certainly even a little bit more so MDMA. So there's that screen. And then there's preparing people for it and knowing the people that they're going to be with. So having some, as much as one can be, like a knowledge of the potential range of experiences that can unfold. So even though it still might be sort of ontologically shocking, you still want to minimize. You don't want to say, I had no idea that like this, whatever effect, like I had no idea that I could feel that I'm going to die. Now, maybe even if you have that warning, you're still completely shocked at how real that can feel. But once you do their best to kind of minimize that by saying like, yeah, plenty of times, even though we know a lot about their physiological safety, especially when people are well screened and monitored, you might really feel like you're going to die because it's that intense, so you want to warn people about these things. And you don't want them interacting with strangers. You want a good rapport between, call them therapists, call them, guides, out there in broader context, their friends, sitters. You want, the classic example of someone freaking out. They're at a concert, they're around hundreds or thousands of people they don't know. Yeah. Some of those people you shouldn't trust. They might steal your purse. They might sexually assault you. There's actually a kernel of truth there that might then be amplified, so that paranoia, that can add to the potential for paranoia. So that's important, and the person being monitored. There is some risk. Again, I don't want to overplay it, but there is a reality here that any intoxicating substance, someone could do something unwise during that period of intoxication. And even beyond just the normal kind of accidents that you can get with other psychoactive substances like alcohol, there's the additional layer, especially at high doses, that your ability to test reality at the most extreme doses and levels of experience, one might feel that, oh, what I'm experiencing isn't even real. And so you can get situations where someone might, think, oh, like, could I fly if I jumped out of the window? And again, this is not typical, but there are some cases that look very real where people were so out there and they were in an unsafe setting, and someone wasn't, keeping them safe, where they did do very stupid things and ended up dying because they were so far out there. So, it's just not a good idea to mix any strong psychoactive substance like alcohol, or psychedelics with being near heights. I mean, I get concerned about some of the Oregon programming if people are conducting sessions in some of those beautiful mountains. I used to live in Eastern Oregon. There's some beautiful settings that would, in some sense, be really great for psychedelic sessions. But, I would be very concerned that no one is near a cliff, and actually read an anecdote of someone who actually felt that they were at risk because they were allowed to be sitting on the edge of a cliff when they're experiencing a mushroom effect. So, and then follow-up care more for, to make sure the person isn't experiencing any lingering symptoms. Most people don't, but any distressing symptoms. But if they are, it's important to address them and make sure that the person gets any help that they need. And then Susan tacked on, and this is really great because it's where I've been trying to put my focus, the ethics. Like, those are what I've described so far are the more acute, well understood risks, the bad trip, the destabilization of those with mental illness, the heart disease risk for those at the more severe levels. But then you get the more insidious risks. And that is, we know that these drugs increase suggestibility. These are extremely powerful experiences where, under these optimized conditions, in the research I've done, in many cases, the majority of people in the study will say it was one of the top 5 most meaningful experiences in my life. And about 20-30% will say it was the single most meaningful experience in my life. That comes with a great gravity and ability to be abused by the practitioner. So there are cases of, for example, sexual relationships developing between therapists and patients. And I've seen, just in a number of ways, even in some of the work that I've conducted, this psychedelic exceptionalism, I call it, this idea that these experiences are so big and the effects on it really cuts through all of these other layers of reality where, we're just, two human beings, and all these other roles are kind of superficial, and it can really set the conditions for which people violate boundaries. These boring old ethical, rules and the wisdom that's been developed, over the decades, there can be a tendency to throw those out the window. And I think it's the exact opposite that we need. Because of the magnitude of these experiences, it's even more important to cling to the wisdom of those boundaries. And we will see, it's just a matter of how much, we will see, as this work expands, doctors stepping into the role of a guru or cult leader. And then you're going to find out, yep, they were sleeping with, all their patients, and they were swindling all kinds of money out of people. I mean, they're the ones bringing, in a lot of people's description, they're allowing people to meet God. Some people would describe it that way. And like, whenever you have a situation, and you have, even amongst supposedly credible scientists, you see open narratives by some of saying this work is going to save the human species. And it really is spoken about in like such, I would say, egotistical language and unbalanced language that fails to fails to learn from the examples from the 60s, where there was a lot of good, but there were a lot of lessons to be learned. And it's that destabilizing aspect. The field can have an egomaniacal aspect to it. And early researchers were well aware of it. Sidney Cohen is one of my heroes, and he did some of the best work with LSD in the 50s and 60s. And I mean, he came to the conclusion, like, there's a real pattern here where psychologically unstable individuals are attracted to this field. It can attract extreme types, and it can lead to a very unbalanced cult-like vibe. And so that's something, there's a lot of ethical issues that are going to come to the forefront as we continue to develop these compounds. And I don't think I'm not convinced that we shouldn't develop these medically for that reason. I think we need to keep that on our radar screen and just do the best that we can in terms of professional training, in terms of transparency, having mechanisms in place to address these risks, just being open about it like I am now, and getting ahead of these issues.
Yeah, this is fascinating to me because one of my fields is ethics. So I'm super. So for best practices, in terms of the potential for what you've called the guru effect, how would you say that therapists or people who are with a person who is experiencing a psychedelic effect, if issues of spirituality or thoughts about God or those kinds of things come up, how should the therapist handle those issues?
Yeah, that's a great question, and I've spoken quite a bit and written about this. My take is that it is just critical to let the patient or client drive the bus with any religious, supernatural, or metaphysical interpretation. And so this has been mischaracterized. My stance has been, including by colleagues who misinterpreted it as saying, well, we need to do this in a cold clinical environment, and we're not going to allow the patient to talk about spirituality, and we have to impose materialism. And that's absolutely not the case. If the patient thinks they were visited by, Jesus or plant spirits, or they had visions of Buddha, or you name it, could go on and on and on. All of that is welcome. And I would say this is very similar to the stance of a quality secular mental health professional when it comes to these things. If your client says that they're a Christian and they bring up their faith, it's not like they say shh, don't shush, don't talk about that. You can't. But at the same time, your role is not to introduce you're not a priest, you're not a pastor. Your role isn't to introduce or to impose those perspectives on people, but you can certainly, and you should, work with people and allow them to bring up these meaningful lenses through which they are viewing life, and simply let them make any of that interpretation. And in fact, this is the way that chaplains operate, who are prepared to work with people at the spiritual level, whether the person's from their faith or another faith, or has no nominal, religious faith at all. They're prepared to just let the patient drive the bus when it comes to that. And so it's really about not introducing things. I mean, one time, just lots of examples, but one time a colleague introduced, oh, it sounds like you're telling this patient, it sounds like you may have had a Kundalini experience. Like, oh, really? What's that? And the patient reads up about Kundalini, becomes very concerned because they read that you could die from it, and it has all these implications, and it's not just a mystical experience. It's kind of more so, and it can be really dangerous. And this is just something that we have I'm not saying that Kundalini isn't is or is not a real thing. It's just something that I can't speak to as a scientist or a mental health professional with any credibility, and it's not my place to introduce it into the conversation, or to, same thing as, you name it, chakras or Jesus or Buddha. And so, my stance is just, be open, let the patient drive the bus, but let's not. Unfortunately, we have a pattern of setting up these session rooms with, Buddhas and other Eastern religious symbols, which I have nothing against personally whatsoever. fact, those are very, calming images for me that would be totally fine if I was sitting there. But I think, just sort of like having such religious iconography ignores the fact that, there may be some people out there we're not hearing from that view that say, well, this isn't for me, whether it's, say, a Muslim or a more fundamentalist Christian or a Richard Dawkins style atheist. And I've seen people of all of these types helped by these treatments. And so I don't know, why would we, kind of paint this treatment through a certain lens that sort of like lets certain people know like this isn't for you. And, it's just not our place to, I think, be answering those questions. I can tell you what receptor in the brain is hit. I can tell you under what conditions these experiences tend to be more meaningful and safer. But was your psilocybin experience a glimpse of God? Was it a glimpse into other dimensions? Was it a glimpse into, plant spirits? Like, your guess on that is, I tell my patients, like anything like that, like, your opinion is just as valid as anyone else on the planet, including mine. I have zero expertise on those questions. And I don't think I need to. And I think you could open to and support the person in whatever meaning at that level. And some people, this stuff doesn't come up at all, and that's fine. But you're there to support them, not to color the nature of the experiences for people.
That sounds so consistent with many classical ethics precepts around professional ethics being client-centered, not abusing power or authority. I'm so glad you're doing that work. It really sounds very important.
Yeah, and it really, it's continues to be astonishing to me. It really steps on toes. I published a commentary a few years ago on it, and I have to remember, like, the vast majority of feedback has been overwhelmingly positive. Like, oh, thank goodness someone finally like said this, that type of thing. But, there's still, some people just take real offense to it because it's inconsistent with what they're doing. And yeah, so it's good to hear that it's, consistent with lots of what, is discussed about in the field of ethics and mental health.
So I want to just spend a couple minutes, our time's running out here, but talking again about the FDA and their recent recommendation against approval for MDMA for PTSD. And I assume that some of the reasons for their decision would also apply to other psychedelic drugs that might be involved with different types of disorders. I'm wondering, could you maybe explain a little bit about what you think can be done to maybe remove that disapproval from the FDA, and also maybe the problems with double-blind studies, if you could talk a bit about that.
Yeah, there were really a handful of issues, one of which was the blind. And so I'm very curious where the FDA itself will land in their decision, because a couple of things brought up by the advisory panel, which is not a binding, it's just advice, literally. The FDA, sometimes disagrees and approves something where the vote goes against approval at the advisory panel phase. But there's a couple issues where the FDA, where it may very well be that the FDA doesn't weigh that opinion at all. So one is the blind. So the FDA has been clear from the beginning that they fully recognize that it's not going to be possible to successfully maintain a blind. And what they said they'd be satisfied with is, for a disorder like PTSD, is to have independent raters in your assessment and have the double blind with randomization. And I would argue there's still value in that, even if the vast majority of people do cut through the blind. And just to make sure people understand that jargon, that means if you're giving people placebo versus the real drug like MDMA or the psychedelic, they're not told what they're actually receiving. Cutting through the blind means the number of people who correctly guess afterwards, oh, I think I got the real MDMA, or, oh, I think I got the placebo. And so you can assess this by simply asking someone and doing things like measuring their confidence in that answer.
Yeah, I think I heard you say once that 95% of the people who are in these drugs, the people who are on placebo will sometimes 5% be able to not recognize, but everybody who gets the drug knows that they got the drug.
That's virtually the case. Yes. Everybody, or almost everybody, I've done some systematic research, and that was true in this case with MDMA. I think there was don't quote me on the exact numbers, but it was that essential pattern. I think there was like one person that got the MDMA in the phase 3 that thought it was placebo, but the larger number of incorrect guesses were the people that got the placebo who thought it was MDMA. So once you get the real thing, it's very, very infrequent, almost never, where the person is fooled. But nonetheless, I would argue there's value in conducting the double blind. And to me, the biggest, I wish the FDA didn't weigh. I wish double blind wasn't the only metric. And I think this is different in the European Medicines Agency, and they're more interested in the comparative efficacy study. It's the reason why my second work with tobacco addiction with psilocybin, I've done an open label recently completed where I'm comparing it to nicotine patch treatment, but there's no blinding. So, to me, there's limitations to every experimental design, and you ultimately get the lesson. You let the data tell you by looking at there's always pluses and minuses with each particular type of study. It takes an individual to weigh that when looking across the literature, and particularly when you see amongst all of the different methods that are tried, if you get the same signal, then that tells you something. So I do think there is nonetheless value in the blind, and the FDA, even if it's successfully cut through, so to speak, and the FDA had agreed to that, and has really sent the signal many times that they're not going to be judging, turning down drug applications because of this issue. They just want researchers to do them as much as they can to address the issue. And so I'm not sure that the FDA is going to weigh like the advisory panel is concerned about that. And the other thing that the advisory panel was one of the other things I should say caught up on was this nature of the psychotherapy. And so the rub here is that FDA does not regulate psychotherapy. And so this whole psychedelic area has been very awkward for them because they really don't have the regulatory mandate to make dictates about how psychotherapy is done or even if it should be done. So a lot of the criticisms about, the sponsor Lykos had used a non-standard psychotherapy that certainly has some criticisms. I think I frankly wish they would have started from the beginning from using something like prolonged exposure therapy or cognitive processing therapy, more empirically validated methods that we know can help people we know are successful in treating PTSD. The biggest issue with them being dropout, but when people go through it, they have a very decent, much better than the medications that have been approved, the SSRIs for PTSD, which really have a trivial effect. But they used kind of something based in transpersonal psychology, which kind of has some, to speak loosely, some woo-woo vibes. And I think that caused some critique, and there's also some concern about about compliance and monitoring. How do you know the therapists and the different groups were doing the same thing? Well, you still got a treatment signal despite any noise that was in the system in terms of therapist adherence to the manual. So I wasn't concerned about that. And again, the bigger point being that FDA isn't charged with regulating the therapy. So on those two dimensions, it may be that the FDA completely throws out the concerns that the advisory council had. But then there were other issues surrounding reports of data integrity. In some of the phase 2 work before the phase 3, there was a sexual relationship that developed between patient and one of the therapists that totally falls within that concern that I shared earlier. And still under the investigation are some questions about supposedly serious adverse events that were underreported by the sponsor. And so while I don't know all of the details, and again, it's currently under investigation, I would say there is this overall concern is like, does some of this fall under this, at least the appearance of an issue, which is an issue in and of itself, like conflict of interest. It's this sort of like psychedelics are saving humanity and this kind of cult-like vibe to the field. Like it has some of this contributed to a minimization of reports of harm. Again, so that's some of the concern it's that specter of this kind of therapy cult. It's been called. Yeah, I mean, my like at the initial at the conclusion of the advisory panel, my thought was, I would have voted for approval, but with a very strong REMS, the risk evaluation mitigation strategies. These are the rules, the program of rules that the FDA can impose. They could say, yes, we approve this, but here are the guidelines under which, and that can include things like you can't send people home with it. You have to, and I think the precedent here will set a precedent because I'm not sure. I think there are some gray areas surrounding, like, say, that therapy aspect where it's not even sure, like, what exactly is appropriate to fit into the REMS in terms of, again, because they're not supposed to regulate therapy. So there's a lot of questions out there. But I think one positive aspect is that it, like, feeds every sponsor, every company that's out there developing psychedelics was, like, listening to this and has, like, digested the lessons from that advisory council, and I think, if MDMA is not approved, it doesn't seem that that psychedelics are going to be shot down on principle. A lot of the concerns is like the way that the sponsor conducted the trial. So I don't think there was a vibe of like, oh, psychedelics, we just can't, we're so afraid of them, and some sort of conspiracy against psychedelics. I really do think most of the concerns were about like the way that the trial was conducted, and so sponsors are paying attention to that, and hopefully that will be a positive lesson for the field.
For sure. And for the broader field as well, because I feel a lot of concern about unregulated use, where if it's not approved for therapeutic, if say psilocybin's not approved for therapeutic use, it's very easy to obtain anyway. And so people are just going to do their own thing without any of the safeguards of well-trained advisors with them and that kind of thing. And so I hope the FDA takes all of that into account as well.
Right. And so I think there's lessons from the from the cannabis realm, in that I think big picture, one of the things to me is that we've probably allowed more harms to happen by the federal government is finally saying, okay, now we're planning to, reschedule to Schedule 3. I mean, they've made themselves completely irrelevant when half the country under state law and you saw early on, especially like states doing just crazy stuff because they're not used to regulating medicines. And so well, you need to like label your potency, but there's no law preventing them from, sending their samples out to 30 different labs and then using the highest number that comes back from one of those labs, kind of simple stuff that, the FDA's been operating for 100 years that like has some experience. And so like in my view with that, it's like we've, by burying your head in the sand, it's like it or not, certain things are happening. Do you want to have relevance or not? Do you want to minimize some of the real harms and help to have some say in shaping things? And if you're too extreme in terms of, disallowing things, then you have no say. And so like, that's consistent with your point, Susan, that like, we don't, like, people are going to be going on retreats. They're doing underground therapy. There's a lot of stuff going on, and vets going down to South America to seek treatment for PTSD. And it's like, well, we need to do it in the right way, but it's kind of sad. Like, they should be, if there's some efficacy here, they should be able to do that in the good old US of A in their own country under medical supervision and not be at risk to, additional risks, with unregulated folks. And then if something goes wrong, there's accounts of people being sexually abused by a shaman, or in one case, someone even dying, and then they just, throw their body in the jungle, and, rare, but this stuff happens when you're in the complete, black market, when you're completely in the shadows. So, if we're in the regulated system, something goes wrong, at least people are losing their licenses, they're potentially going to prison, if they're doing something that's putting people at harm. So yeah, we need to keep in mind the risk of not doing anything and staying irrelevant.
So Matt, I think we need to finish up, but before we do, I'd just like to ask you about what your current priorities are for the research. And where do you think the field's going to be 5 years from now?
So my main focus now is continue to work on this smoking cessation work, finishing out this multi-site phase 2 double-blind study for psilocybin for smoking cessation. I've also got some work I'll be starting soon using LSD to treat chronic pain. And I'm generally more interested broadly in understanding how these treatments, the commonalities across these treatments, and not just kind of racking up like new disorders that can be treated.
Yeah.
I'm more interested in understanding this general mechanism of behavior change, this seemingly increase in agency that people have when these experiences work well, understanding that, and then figuring out how to maximize that. And then really also doing science around how we conduct these therapies. There's still basically zero experimental science over how psychedelic therapy is conducted. All the experimental work has randomized people to, drug or placebo or different doses of the drug. But in terms of, how much preparation do you need? How much so-called integration do you need? Is it better to do talk therapy during the session or have them close their eyes and introspect and talk about it afterwards? Is it,
Sure.
Everything we're doing now is completely based on methods that were first published in 1959.
Yes.
And so I'm really interested in moving more into the science of how these therapies are conducted and how we can optimize them, because it would seem crazy that even though they're working usually like astonishingly well, it would be crazy to think, I think, that it's maxed out, that we can do anything like for example, if there is this period of increased neuroplasticity or enhancement, propensity to learning afterwards, like what could we be doing to take advantage of that? Just an informal discussion the next day is typically what's done. There's plenty that we could speculate that would be reasonable to try and to do scientific studies around. So that's a lot of where I think the field is going to go and what I'm interested in doing.
Well, we can't wait to follow your work. It's such
Yeah.
important, so important. Both your research and your writing on ethics and best practices, so important.
Great. Thank you.
So, Matt, thanks so much for joining us today. It was a really stimulating and informative conversation that we had. Know a lot more about the issues than I did before. And I also appreciate how much your work is going to advance understanding of the use of psychedelic drugs in therapy. So we appreciate you being with us very much.
Oh, thank you, Terry and Susan, and really enjoyed the conversation.
Wonderful. So did we. Thank you so much.
Well, that's it for this podcast episode. Thanks very much for listening. And as always, we welcome your feedback at neuroscience.policy@american.edu. We hope you'll join us again for our next episode. And do let us know if there's anything in particular you'd like to hear more about.